ঠিক আছে, আজকের টপিক হচ্ছে ক্যারিওটাইপ অ্যান্ড সিনড্রোমস। ঠিক আছে, মেনলি মোস্ট কমন কিছু সিনড্রোম যেগুলো পরীক্ষায় আসে সেগুলোই আছে। ঠিক আছে, ফার্স্ট ডাউন সিনড্রোম। তো সাইটোজেনেটিক্স, what is the cause or factor behind Down syndrome? Most common is non-disjunction. In 94% cases, non-disjunction, chromosomal non-disjunction is responsible for Down syndrome. This non-disjunction may produce an extra copy of chromosome 21, that is trisomy 21. May be of maternal or paternal origin, but high chance of maternal origin in cases when the mother conceives at older age, that is more than 35 years, high risk of Down syndrome. In 94 to 95% cases, non-disjunction is responsible. In 4% cases, translocation between the chromosome 14 and chromosome 21, and in 1% cases, mosaicism. That means two cell lines are there. In one cell line there is 2 chromosomes and in another cell line there is 3. So that is around 1% cases this is responsible for Down syndrome. So most common is non-disjunction. Then clinical features of Down syndrome: mental and physical retardation, developmental delay, flat faces, upward slanting of eyes, that is Mongoloid Slant. Position of outer canthus will be at higher than the inner canthus, that is Mongoloid Slant. Then epicanthic folds, extra folds at inner canthus of eye. Then oblique palpebral fissure and low set ears. If we draw a horizontal line from outer canthus of eye, that ear will be below down that horizontal line, that is called low set ears. Then small nose with flat nasal bridges. ঠিক আছে, তারপরে ন্যারো শর্ট প্যালেট উইথ স্মল টিথ অ্যান্ড প্রোট্রুডিং টাং। ঠিক আছে, প্রোট্রুডিং টাং, হাইপোটোনিয়া অ্যান্ড স্মল স্কাল উইথ ব্র্যাকিকেফালিক। ব্র্যাকিকেফালিক means flat occiput. So these are the features a patient of Down syndrome will present with. These are 3 pictures, that is at 3 months, at 15 months and at 2 years of age. This is more prominent Down syndrome, that is Mongoloid Slant is present, flat nasal bridge, that there is a protruding tongue. Okay. Other clinical features: short and broad hands. Then clinodactyly, that means hypoplasia of middle phalanx of 5th finger. Simian crease, that is single palmar crease, that is called simian crease. And sandal gap. Sandal gap is the gap between great toe and second toe. This is sandal gap. So all these features are present in the patient of Down syndrome. Then what are the associated abnormalities? First, congenital heart disease, most common. The defect we will found, that is endocardial cushion defect. Then GI problem, gastrointestinal, that is most common is duodenal atresia. Also there is increased risk of annular pancreas and Hirschsprung disease. Eye problems, increased risk of cataract, nystagmus, squint and abnormalities of visual acuity. Hearing defect, prone to serious otitis media. Okay, so we have to screen for these abnormalities or defects whenever we will get a patient of Down syndrome in OPD or IPD. Then thyroid dysfunction, hypothyroidism in 13 to 54% cases. Thyroid function test recommended during neonatal period. Mostly in day 3 of life, we do the thyroid function test. Then atlanto-occipital subluxation, displacement of atlanto-occipital joint in around 10 to 30% cases, and this is important because this can cause cord compression. What about physical growth? Linear growth is retarded and they will become obese with age. As I told earlier, hypotonia is a feature of Down syndrome, but tone will improve with age. But developmental progress slows with age. So there will be developmental delay. Regular follow-up for height and weight is necessary for measuring growth and development. Then malignancies, prone to severe malignant or lymphoproliferative disorders. What are they? ALL, acute lymphoblastic leukemia, AML, acute myeloid leukemia, myelodysplasia, and transient lymphoproliferative syndrome. Diagnosis. Prenatal diagnosis, how to diagnose prenatally? That is, what are the indication for screening? Mother's age is more than 35 years. Any previous child with Down syndrome. Then translocation carrier state in parents and any history of genetic defect in family. এই কন্ডিশনগুলো থাকলে আমরা ডাউনসের জন্য স্ক্রিনিং করব। এখন মোস্টলি সব মাদারদেরই স্ক্রিনিং করা হয়, বাট দিজ আর দ্য হাই রিস্ক ক্রাইটেরিয়া গুলোতে স্ক্রিনিং ম্যান্ডেটরি। কি কি টেস্ট করব? ইন সেকেন্ড ট্রাইমেস্টার 4 টেস্ট, দ্যাট ইজ ফ্রি বিটা এইচসিজি, বিটা হিউম্যান কোরিওনিক গোনাডোট্রপিন, আনকনজুগেটেড ইস্ট্রায়ল, inhibin and alpha fetoprotein. This is known as quad screen. So quad screen in second trimester, it can detect up to the 80% of Down syndrome pregnancy. And in first trimester, there is a method that is Nuchal Translucency, NT thickness. We will measure either alone or in combination with beta HCG and pregnancy associated plasma protein A. Okay. So in first trimester, nuchal thickness, beta HCG, pregnancy associated plasma protein A, and in second trimester, quad screen. In first trimester, nuchal thickness alone can detect less than 70% of Down syndrome pregnancy, but with beta HCG and PAPA, pregnancy associated plasma protein A, the detection rate will increase up to 87%. And if we combine both first and second trimester screen, the detection rate will be up to 95%. Again, screening test in first trimester, measurement of nuchal translucency. Second trimester, same, increase nuchal fold thickness, and we will get short femur and short humerus. Triple test in 16 weeks. What will we get? Decreased alpha fetoprotein, decreased unconjugated estriol, and increased beta HCG. The method of doing fetal karyotype is CVS, chorionic villus sampling, and amniocentesis. and it detects Nondisjunction, translocation or mosaicism. Then how to manage a case of child of Down syndrome. Principle of management is early stimulation, physiotherapy and speech therapy, as there will be developmental delay, speech delay. Associated problems to be treated, maybe cardiovascular, hearing defect, eye defect. Then social performance is usually achieved beyond that expected for mental age. So there will be social delay. Then they behave as happy children. Down syndrome children are always smiling faces, present with smiling faces. They are friendly, okay, they enjoy music, they have good sense of rhythm, so they will play with you and come with smiling face. Mortality, major cause of early mortality is congenital heart disease. Other diseases are chronic rhinitis, conjunctivitis, periodontal disease and lower respiratory tract infection and hematological malignancies. So these all are causes of mortality, but most common is heart defect. Counseling, how to counsel the parents. First, inform as early as possible about the diagnosis. Then talk in simple and positive language. Discuss the known problems and associated problems. Inform about recurrence risk and possibilities of prenatal diagnosis if they opt for having a second baby. Now, what are the risks of recurrence? Women aged 35 years or less who have a child with trisomy have 1% risk of having another, and risk will increase if the mother is more than 35 years old. For translocations inherited from the mother, the risk is about 10%, and if the translocations inherited from father, then the risk is 4 to 5%. Next is Turner syndrome. Turner syndrome, it only affects females. This condition is caused by abnormal chromosome 45XO, the most common chromosome pattern, and is named after Dr. Henry Turner. Now, types, cases of Turner syndrome where an X chromosome is completely missing, that is 45XO, that is called classical Turner syndrome, and 30% cases are only missing the X chromosome in some of the cells. In some of the cells X chromosome is present and some of the cells X chromosome is absent. This mixed pattern is known as mosaicism. Then girls with this pattern have fewer symptoms, less symptoms, because some X chromosomes are present there, normal X chromosomes. Now, clinical features or characteristics: being shorter than average in height, so height will be short, lack of development of ovaries leading to infertility. So these are the clinical features. The child will present with first short stature, then low hairline, shield-shaped chest, then widely separated nipples, shortened metacarpal fore, small fingernails, then brown spots, it's called navy, then characteristic facial features, then fold of skin in neck, heart defect, constriction of aorta, most common heart defect in Turner syndrome, constriction of aorta, aortal defects, then poor breast development, elbow deformity and rudimentary ovaries. This is most important. Rudimentary ovaries, underdeveloped gonadal structures, gonadal strip. These will lead to infertility and no menstruation. Okay, so short stature, loss of ovarian function, hormone imbalance will cause thyroid, diabetes problem, stress and emotional deprivation, bone disease, learning problem. Now treatment, first height monitoring, at height is less than normal, then cardiac evaluation for coarctation of aorta or any other disease of aorta, thyroid screening, ovarian hormone replacement and growth hormone therapy. Next is Klinefelter syndrome. Klinefelter syndrome 47XXY. Here is the karyotype. You can see one extra X chromosome. So this is called 47XXY or XXY male. This extra X chromosome is retained because of a non-disjunction. During meiosis 1, paternal in 46% patients and meiosis 2 in females, maternal in 54% patients. Actually in non-disjunction, either the one chromosome is added extra or any chromosome may be deleted. Causes in aneuploidy, that is called aneuploidy. So here one extra chromosome, X chromosome is there, that will cause the chromosome 47XXY. And this problem occurs during division, that is cell division, that is called meiosis. Now what are the clinical features? First is weak muscles, then slow motor development, takes more time to sit up, crawl and walk. There will be speech delay, quiet personality and undescended testes. Taller than average stature. In Turner syndrome, height will be less. In Klinefelter syndrome, height will be more. Gynecomastia, longer legs, shorter torso and broader hips. Bones will be weak, absent, delayed or incomplete puberty, low energy level, shyness. After puberty, less muscular bodies and less facial and body hair because of delayed puberty. Then difficulty expressing feelings because of shyness, small firm testicles, problems with reading, writing, spelling, small penis and attention problems. Testosterone treatment should begin at puberty. These can normalize body proportions and promote development of secondary sexual characteristics. But it does not treat infertility, gynecomastia or small testes. Speech therapy and behavioral therapy for speech and behavioral problems. For gynecomastia, aromatase inhibitor, then surgery. Now trisomy 18 and trisomy 13, less important. Trisomy 18, Edwards syndrome, clinical features, failure to thrive, developmental delay, hypertonia, tone will be more. that is differentiating. Micrognathia, shield shaped chest, short sternum, okay. Then joint abnormalities, and this is important, rocker bottom feet, okay. And congenital heart disease is common. Symptomatic management, this rocker bottom feet is very important for both MCQ purpose and clinical purpose. Trisomy 13, Patau syndrome. What are the clinical features? Developmental delay, failure to thrive, microcephaly, cleft lip with or without cleft palate, Holoprosencephaly, microphthalmia, iris coloboma, retinal dysplasia and cataract, overall eye problems, deafness, ear problems. So, congenital heart disease 80%. Most cases die by 6 months of life. So, congenital heart disease is almost common in every chromosomal syndromes. Again, here management is symptomatic or supportive. This is a case of trisomy 18, facial dysmorphism and overlapping of fingers. Okay, you can see the overlapping of fingers. And this is rocker bottom feet. You will found both in trisomy 18 and 13. This is a dysmorphic faces. This is a patient of child of trisomy 13. This is Holoprosencephaly. Cerebral hemispheres are not divided here. No corpus callosum is there. Okay. What is karyotyping? Karyotyping is the profile of individual's chromosome. It is a technique to examine the chromosomes in a sample of cells which can identify the genetic problems like these syndromes. What is the purpose? To locate or visualize the change in the chromosomal pattern. Karyotyping done on 3 patterns on the basis of size of chromatids, bending patterns and on the basis of centrometric positions. In metacentric, centromere position is at the midpoint, then submetacentric, here there is short arm P and long arm Q. Acrocentric, short arm is very short and long arm is very long, and this is telocentric, here no short arm, only long arm. So, through karyotype analysis, we get species identification, validation of normal diploid karyotypes, normal জানার জন্য karyotyping করতে হবে, numerical chromosomal abnormalities, monoploidy, polyploidy, monosomy, trisomy, ডিলিশন, ক্রোমোজোমের ডিলিশন হচ্ছে ডুপ্লিকেশন, ট্রান্সলোকেশন, ইনভার্সন, ক্রোমোজোমাল যে কোনো চেঞ্জেস জানার জন্য ক্যারিওটাইপিংই একমাত্র মেথড। ঠিক আছে, এটা একটা নর্মাল ক্যারিওটাইপ আছে 46XY, কোথাও ডিলিশন বা ডুপ্লিকেশন কিছু নেই। 1 খানে ক্রোমোজোমেরটা সব থেকে বড়, আস্তে আস্তে লাস্টের দিকে ছোট হয়েছে। ঠিক আছে, এটা একটা নর্মাল ক্যারিওটাইপিং 46XY। এটাও আর একটা নর্মাল, again this is 46XY। এখানে কিন্তু একদম 1 নম্বরটা সব থেকে বড়, আস্তে আস্তে কিন্তু যত নিচের দিকে গেছে ছোট হয়েছে। তাহলে কি কি কন্ডিশন সেগুলো আমরা অলরেডি জেনে নিয়েছি, ডাউন, টার্নার, ক্লাইনফেল্টার। একটা এক্সট্রা লেখা আছে ফিলাডেলফিয়া ক্রোমোসোম, যেখানে ABL BC এর একটা ট্রান্সলোকেশন হয়, ঠিক আছে। অনেকগুলো সিনড্রোম আছে, ক্রাইডু চ্যাট আছে, অনেকগুলো আছে। মেন, ডাউন, টার্নার, ক্লাইনফেল্টার, এই তিনটে মোস্ট ইম্পর্টেন্ট।